Good evening, everybody. Thank you for joining us this evening. And apologies right away for the initial problem on the link. This is the first time we've attempted an event of this nature. So inevitably, we've all been on a bit of a learning curve. But hopefully, most of you have been able to get into the meeting. And I want to thank the Practice for making the time to put this event together and answer the questions that you've put forward. So tonight we have Steve Sharpe, who's the Practice Manager at the Practice, and Dr. Kate Thomson, who's the Managing Partner. And they'll both be answering the various questions depending on the nature of the question. And then I'm the acting chair of the patient group and the newsletter editor, which I'm sure you're all familiar with. So I'll give a brief overview of the patient group, and then we'll head straight into a practice update and then the questions raised by patients. I should mention that you'll see Ellie Gooding's name at the bottom of your screen, possibly. She's the one who's kindly operating the slides. So thank you to Ellie. So let's move rapidly on and to the patient group overview. And I'm not going to spend a lot of time because we want to spend most time with the Practice answering the various questions that you've put forward and giving you an overview of what's been happening. So our patient group represents patients across the Practice, and we have three subgroups based Tring, Berkhamsted and Markgate, and we all meet up together with representatives of those three groups on a regular basis with the Practice to talk about issues that have been raised by patients. And our aim really is to help Practice operate better for all patients. As I mentioned, the subgroup representatives, they meet regularly with the Practice staff, and through the newsletter I invite patients to put forward any issues that they may have, any questions they may have, and then we boil all that down so that we don't repeat ourselves for those joint meetings. Patient involvement in healthcare means that it helps us to maintain high standards and improve communications between the Practice and patients. It's very important that as many patients as possible join us to ensure that all voices are heard. And I think it's instructive to note that from the survey of the newsletter readers are predominantly over 55. So about 80% of the readers of the newsletter are over 55. And that doesn't necessarily mean that they're the largest users of the Practice, because that's not shown by other statistics. And for the age group under 44, only 9% of them are readers of the newsletter. So we really want to improve the demographic spread of the patients who are A, reading the newsletter, and B, joining the patient group and helping us to work with the Practice and improve the service with patients and improve the communications between Practice and patients. And if you'd like more information about the Practice, if you go onto the on the patient group, you go onto the Practice website and you'll see under the patient group a lot of information and background on how the patient group operates. So without further ado, I'm going to pass it over to Steve to kick off with the Practice update.
Steve, you're muted.
So firstly, thank you to everyone for attending this evening and the opportunity for us to present to you and hopefully answer the questions that you've raised. Where we haven't been able to answer them, we'll put them in a written answer afterwards, which will be available, I think, through George and the PPG newsletter. So the first thing we just wanted to provide was a short update on what we've been up to over the last few months. So if we can first show you what our service performance report has been, and this is something which we produce and put on our website each quarter. So it's just kind of three things which I just wanted to point out to you really, and it just gives an idea of the scale of what we're working at. So in the last 3 months of 2023, we had over 57,000 appointments, of which 85% of those appointments which needed to be booked within 2 weeks. And each month we also send out a questionnaire to patients who have visited during a specific week that month. And in that quarter, it doesn't say exactly when this one from that last quarter, but that's showing a 91% of patients who visited us thought we were offering a very good, or a good service. So on the whole, we're achieving quite a lot, but we must never kind of rest on our laurels in how we are kind of producing and the delivery of service to our patients. George, do you have the first question?
George, you're muted as well.
Yes. Do you think the practice is patient or doctor-led?
I think we are very much patient-led. I think which is very much demonstrated by the values in our patient charter of caring, respectful, and continuity. If I just bring that up on the screen for you. So this is our patient charter, which we have at each of our branches, and these are the values which we kind of aim to deliver to our patients through named GP, multidisciplinary team, listening, being accessible and innovative. That patient charter is also available on our website. I think we're patient-led in terms of choices that we make with the care and the outcomes which our patients are wanting. I think we're patient-led in terms of having the appointment type that our patients want, be it telephone or face-to-face. We are patient-led in terms of ensuring that we're able to see the same GP and receive continuity of care. And we are patient-led in terms of being able to see the right clinician at the right time for their medical condition. Any patient which needs to be seen today is seen today. But that has to be taken hand in hand with the resources that the practice has in terms of staff and facilities to ensure we use these as efficiently and effectively as possible and based upon the medical need and priority that patients present to us. It also has to be recognised that as a GP practice, we're contracted to the NHS and public health to provide a range of medical interventions. A lot of work goes behind the scenes in the NHS with the practices to develop these medical priorities in areas such as ours. So we can together develop strategies to improve patient health and develop preventative care. Patients are also involved in these discussions at various levels at local or ICB level. And I believe some of our PPG members are actually part of those discussions. George, next question.
Yes, the next question. What are you doing to overcome the current wait time to get an appointment and the length of time waiting to get through to the practice?
This is obviously one of the key things which patients in any survey always raise with practices. So we've been working extremely hard over the last 12 months to improve access to our patients at a time when the demands on the practice and primary care as a whole continue to increase through an aging population and also what is often termed as the worried well. Those who are seeking reassurance or may often have a self-limiting minor ailment that the body will have addressed after a few days. But there's not a silver bullet for improving access to patients. So the areas we have been developing include these. So with the GP appointments, we've been looking at, over the last few months, we've been removing bottlenecks. We have 24 full-time equivalent GPs looking after 43,000 patients, so roughly about 1,800 patients per full-time GP. In removing those bottlenecks, we've got our first presentation routine appointments down to under 2 weeks for 85% of our patients. We use also the full clinical team where patients then don't need to see a GP specifically. So for example, first contact physio for MSK issues, our mental health nurse, We have an advanced nurse practitioner and a paramedic. What this does, it frees up appointments for those needing to see a GP. We've also introduced GP triage, and we've been running that, I think, about 18 months, and Kate will say a bit more about that later. But this allows patients to be seen by the right clinician at the right time based on their medical needs. And we estimate about 25% of those patients who contact us to go on to triage don't actually need an appointment. So those patients can be looked after through advice. Working with our phones, we've had a particular big focus upon these over the last couple of months. We work multi-site, so we have our patient services team working at all of our 5 sites, and they work together. And we've improved our processes. So, for example, in January, we took over 10,000 calls from patients, and we answered those on an average within 4 minutes. In fact, 67% were answered within 5 minutes. The figures on the screen there are actually what happened yesterday. So you can see the majority of all calls were answered within 5 minutes, and with only a smaller portion which took a little bit longer. But what we've also introduced is a free patient callback at busy times, so patients don't have to hang on the phone. That's been a big improvement over the last 3 or 4 months. We've also obviously need to move forward with digital access, so providing simple access to those with digital access, which frees up the phones for those who don't. And we, for those which have used the e-consult, so where patients can submit either an admin request or a clinical request, we currently receive about 500 of those per week. So that's just under 20% of our contacts which we receive from patients, the equivalent of almost a day. And also a big part to play in this also is patient education. Through self-help, the use of pharmacy first, so going to see the community pharmacy for certain conditions rather than coming to see the GP. Also promoting that there's no need to call at 8 o'clock with our GP triage. And also the use of digital tools for admin and clinical issues. I've mentioned e-consult, but improved use of the NHS app and things like that. George, next question.
Yes, this for Kate. How does the triage system work for allocating urgent appointments and the types of appointments available with different healthcare professionals, and how do you make them?
Okay, so I don't have a slide. I'm just going to talk about this. So triage, actually, we started, Steve, 2.5 years ago, and we started this because we had, like many GP practices, problems with everyone on the phones at 8 o'clock or coming in, and all the urgent appointments gone by 8:15. And a lot of unhappy patients, a lot of worried patients, and it was quite tough on our reception staff. So we put in place a triage system. And the first thing to say about that is it is purely for urgent requirements. So it's either a very urgent medical problem, or as patients you feel it's an urgent medical problem, or you don't feel able to wait up to 2 weeks to see your own doctor. So we are open as a practice. You can come in, you can book your appointments online via the NHS app or via the reception team, and that can be booked routinely as you wish at your convenience. So this is for urgent only. And what we wanted to do was make sure that, as Steve alluded to, that patients are allocated appointments based on clinical need. So based on what the problem is, you will be allocated an appropriate appointment. So everything that comes in on a daily basis is assessed, and it doesn't matter if it's at 8 AM in the morning or 5:30, it will still be assessed in the same way. So it can come in via e-consult, which is being used more and more, but often via the phone. and we get a detailed amount of information. We'll often ask for more questions about a specific problem. Then a GP will look in detail at the query, at the concerns, assess the symptoms, have a look through that patient's notes, and then come up with a decision that is appropriate. And those decisions will be, there are many options for what that could be. It may be an urgent appointment on the day. If the own GP is available, our personal lists are really important to us. So if your own doctor is there, there's a very good chance you will see your own doctor. If your own doctor isn't in till the next day, but it can wait till the next day, it's clinically assessed that that is reasonable to do so, that's what we will do, so that wherever possible, patients can see their own GP. And that works well for hopefully patients and in the practice. It might be that we say, actually, what we'd like is some investigations first. So you might get a nurse appointment, you might have an ECG, you might have a blood test, and then follow up with your own doctor. And that appointment would also be booked. It might be an appointment with a physio. It might be an appointment with a specialist nurse for minor illness problems like ear pain and this kind of thing. So it's very much focused on what is appropriate for that problem. And as Steve also suggested, it might be simply advice. And that's where we find, by offering advice, signposting patients to useful information, explaining what's going on, it might not need an appointment at all. And in that way, we are very much more efficient in the way that we use our appointments. So we have more appointments available for patients who need them. It's worked extremely well. We've spent, we started as a pilot 2.5 years ago in Berkhamsted. We rolled it out more widely just about 2 years ago. And we've continued to refine and develop the process as we've gone. And largely, it's had really, really good feedback. The important thing to say is we will deal with everything on the day. And, you know, typically that's around 300 queries across the practice, 300 clinical requests for urgent appointments. So you can imagine no practice can offer that many urgent appointments. So we, but everything is dealt with and assessed by a doctor. So there isn't anybody else triaging other than doctors. And that's the way we know that we can do this safely. We don't send people to out of hours unless it's out of hours. People don't have to call 111 instead because there is no capacity in the practice. So we feel that overall it allows us to offer a much safer service for our patients. And as I say, largely the feedback has been really, really positive. And we get lots of emails saying, thank you, can't believe it, with all the pressures you're under, or GPs are under, and all the media coverage that I actually got looked after. Many queries also, simple things, urine infections, those kinds of things where there are no other worrying symptoms associated with them, will be dealt with by the triaging GP. So the patient will be given a message and possibly a prescription. So how do you get an appointment, you asked, George? You're typically told or advised by patient services of your appointment, of the outcome, the time, and it might also be, you might be advised to go and collect a prescription and given a little bit of advice. So, but everybody is within a few hours usually contacted back with the outcome. So and it works really, really well.
Thank you, Kate. The next question is, how does the practice communicate with patients via text messages? And can you explain the text messages sent out? Sometimes there's no explanation as to why you want to book the patient, why you want the patient to book a certain appointment. For example, starting new medication. And how are patients assigned to a particular doctor? And can we be informed if our regular doctor changes? So that's quite a lot of questions rolled into one there.
Thanks, George. Okay, so how do we communicate with patients via text? So we presently communicate using text only when there's an express consent to do so from the patient, and for us to be able to do that. This could be from our clinical or non-clinical by text. So you can get them from the clinical team or the non-clinical team, depending upon the situation. One of the questions was, can you explain the text message, how it's kind of sent out? So there should always be some form of explanation as to why you're being asked to book an appointment or take a certain action, such as providing a blood pressure, weight or height. Patients with long-term conditions may be asked certain other questions or offered appointments to review their condition. There may also be services you are eligible for, or a change in medication which needs to be determined by the clinical pharmacist or GP. If you're a dispensing patient, we'll also send a text out when your medicines are ready to be collected. If the text is about booking an annual review appointment, for example, we will normally include a link to allow you to make the appointment with the right person. We use this instead of using the NHS app to ensure basically we can get you into the right appointment with the right person at the right time, because quite often we'll run a clinic for certain conditions. The link, though, was greatly reduce the number of words which we can actually use in the text. So it does create some minor problems in how we explain potentially what that text is for and what we would like patients to do. Our team, therefore, will try and include the most important information, but sometimes can't go into too much detail. We are limited on the size of the text which we can use. So an example of a text would be something like, due to your long-term condition, it is recommended that you discuss the possibility of starting lipid-lowering therapy medication. Please use the link below to book a telephone appointment with our clinical pharmacist to discuss. And then there'll be a link at the bottom for the patient to use. We're very careful not to use jargon, which patients won't understand. But actually, on the whole, we haven't had much or a lot of feedback regarding this from patients that they're not understanding what's being sent, but we do recognise we have to be very careful and monitor it very carefully. So the message which we're sending out in our text is understood by the patient. But obviously, sometimes it may just go a little bit awry, and patients can always contact us by e-consult just to confirm exactly what we meant by it. If you're not already aware, and if you do use the NHS app, you can actually receive messages. Instead of receiving them by the text, you'll now receive them via the NHS app. And that's being promoted or starting to be promoted quite heavily by the NHS, because it basically means we're not having to pay for all the text costs. So if we use the messaging servicing through the app, then basically we can do that for zero cost, where obviously if we're using the text, then the NHS has to pay for all those texts which have been going out. I think the other question was regards signing a GP and why we do it, and then how we inform patients. So we aim to contact all patients when there is a change of GP. Unfortunately, the NHS app doesn't actually tell you who your usual GP is, which is a bit of a shame. We tend to change a GP for three main reasons. One, for example, your current GP leaves or retires and is then replaced by another GP. We need to ensure that the patients are being shared equally across all GPs. patients will move away, relocate. So the patient list with each GP becomes slightly out of balance. So we need to make sure, so we can deliver the best care possible, that each GP basically has the same number of patients. And then over time also, those lists a GP may have become what we call kind of out of balance. So that's to do with age, medical conditions, for example. And what we need to ensure is that each GP basically has the same difficulty workload of patients, so everybody basically gets the opportunity for a high standard of patient care. An example would be, if a GP had all of its patients were over 75 and had lots of medical conditions, and another GP had a very younger population, then obviously it'd be much more difficult to have an appointment with the first GP, because they're obviously seeing their patients a lot more than possibly those with the younger population. So we just need to make sure they're all equitable, and that means the main purpose behind it is so we can deliver the best patient care possible to everybody. But we do understand that patients do get tied to their GPs, especially if they've been with them quite a few years. But so we don't do it lightly. Primarily to inform patients, we send texts for those who have kind of given us permission and consent to use text messaging. To that text, we also normally attach a letter which gives further details about the reason for the change and information about their new GP. So we don't normally send a text saying your GP is Dr. Jones and leave it at that. There is a lot more information, and possibly we just need to ensure that patients are aware that there will be normally a letter attached to that text. For those who don't have a smartphone, who can't open up a letter, then on that text it'll also advise them they can get that same information directly from the practice as well. If for those patients which basically don't receive text, where we can, we then do aim to try and send letters out, but obviously our primary aim has to be to do it by the most cost-effective method we can, which is by text message. Yes, it can seem a little bit unfriendly, but with the cost of sending out letters, that is a cost which, for a large practice is difficult to take on if we've got other alternative ways of doing it. We understand that a few questions were raised from patients about this topic today, and any of those which think they didn't receive the correct information when we asked them to change GP, then obviously please accept our apologies. We normally investigate this on an individual basis when we learn about it, just to find out if anything went wrong. But we've only had a few, or a small handful of patients who've actually been in contact with us when we sent out our text with new patient and GP information. But we will confirm and continue to monitor this going forward. One thing which obviously patients did ask for is just to confirm whether their GP is male or female. So again, we'll include that in the text as well. Thanks, George.
Thanks, Steve. Right, Kate, what's the situation for medication supply issues in our area? For example, ADHD, epilepsy, diabetes, asthma. And can it be easier to obtain an alternative medicine when the usual one is unavailable and the pharmacy recommends an alternative? The current process is somewhat complex and lengthy. Two other supplementaries on that. Why can't repeat prescriptions be collected annually, supported by an annual medication review? If not annually, why not quarterly? And last but not least, how do you communicate with community pharmacies when ordering repeat medication? So rather a lot there to cover.
Okay, so let's do the first one. So medication supply issues. This has been a thorny topic for many patients and for us actually for a few years now, and it seems to be that if it's not one medication, it's another. The current supply shortages are around ADHD medication and diabetes medication in particular. ADHD probably partly because there are increasing numbers of people that are receiving a diagnosis, and a lot more people on medication than perhaps the supply chain had forecast. And it can be very difficult to change some of those. Specifically with ADHD medication, there is not an obvious alternative in every situation. So normally that decision about an alternative should be made by the consultant who has recommended that particular medication. So that's specific for ADHD. For other medications, it's much more straightforward for us to be aware of what alternatives we can prescribe. The issue is what is actually available. And that information we don't have either necessarily to hand. It's not something that's provided to GPs. So the best place for that to be done is actually at the pharmacy. So the number one is that we would always request, when something has been prescribed and it's not available, that the patient asks the pharmacy what they have available. Can you hear me, Ellie? Yeah, sorry, it said I was on mute. Good, yeah. So ask what is available as an alternative, and it can vary from pharmacy to pharmacy. So what we will often do then is, once we know what's available, we'll reissue the prescription with an instruction that says, while your usual medication is unavailable. So, and in some cases, it may be that we don't need to have a substitute at all. There's a lipid lowering, so reduces cholesterol medication called ezetimibe, which wasn't available at the back end of last year and coming into January. So what many of us were doing was saying, if no alternative needs to be provided, and just reorder on a regular basis. So we expect that the local pharmacies will tell us what they can get. We do that with our own dispensary, which we do for a minority of patients. But what we don't have the ability to do all the time is to ring around pharmacies and find out who's got what and what's coming in and out of stock. So that's something we would really ask patients to do themselves, and your pharmacist is the best placed individual to tell you what they can get, and then if they can get it, we'll prescribe it. So ADHD was a classic one. The other one currently are specific diabetes medications like semaglutide, the injectable ones, and some of the supply issues for those has been the media reports that this is a great weight loss drug. So lots of private clinics are running down the stocks. And we can't prescribe it. We do have alternatives for some of those, and we offer those directly on a prescription. So it's a case-by-case basis. What can we do to make it easier? To be honest, there's very little, because as doctors, we are responsible for that prescription. If we are told what is available and it can be prescribed, we will prescribe that alternative, and we will try and do that in as timely a way as we possibly can. But it is not, unfortunately, in our gift to be able to turn around alternatives that quickly. Because there's an electronic process that we have to follow. So And it will really depend on what and every month there will be a different shortage of a different medication. And we won't always know what those are until they hit us, I'm afraid. Sorry. The next question, why can't medication just be repeated annually? That is because there are many reasons for that. One is that there is only one way in clinical systems to allow that to be done, and if there's any change, it is impossible to unpick it. Many patients are on multiple medications, and changes are made reasonably frequently, and it would be enormously wasteful to issue a year's worth of medication all at one time. And many medications, because they have various monitoring requirements, which happen more frequently than annually, cannot be done also on an annual basis. For very few, like thyroid medication, where the test is done annually, it's a single medication, we do it on an annual basis via something called repeat dispensing, but we would never issue a year's supply all in one go, because there could be many reasons why that could go very wrong. And also all the pharmacies in the high street would go out of business, so it just wouldn't happen. So what we can't do is have huge amounts of administration of unpicking changes. So in very select cases it can be done, but that would only be on a specific discussion in an annual medication review with your GP, if that answers that question. George, would you be kind enough to repeat the last part, because I've forgotten what the last part was?
Yes, it's essentially how you communicate with community pharmacists when ordering repeat. I think they mean how does the practice communicate with pharmacies, and presumably that's the e-prescription system.
Correct, yes. So the pharmacies can some of them can act, if they have a particular system, can communicate with us directly for prescription requests on behalf of patients. Some do, some don't. It's the choice of the pharmacy. And everything is viewable electronically. So once the doctor issues the prescription, that is immediately available to the pharmacist to pull it down. So I mean, it largely works wonderfully. It's a fabulous system, and it allows us to issue medication to any pharmacy in England and Wales, regardless of where the patient is, in real time. So there is a facility called EPS, so Electronic Prescription Service, any pharmacy. So most patients will have their nominated pharmacy that they regularly collect from. But this facility allows us, if somebody is away and they need an urgent prescription, or alternatively if there's a supply issue, we can issue it electronically, any pharmacy, simply by that being requested, and the patient can walk into any pharmacy in England and Wales, and that can be pulled down electronically and be issued. So that's one of the ways we've used to get around some of the supply issues recently.
Thank you. The next question is, would you consider the use of advanced decisions at the practice? And I'm going to add a supplementary to that, which is vaguely related, which is, should a patient inform you that they have enduring power of attorney?
Okay, yes, they are a lasting power of attorney, enduring power of attorney is separate to advanced decision. So if I do the advanced decisions first, yes, absolutely we do. And it is something that has been done on a case-by-case basis, but we have a plan to formalize that more and have it templated so that any patient can discuss their advanced care decisions with their GP, have that documented, have a printout of that and keep it in their home, so that can be shown to paramedics, to carers, and we would actively encourage those discussions to happen both with the patient and their GP, but also family members, so that everyone is aware what those important decisions are, and that a patient's wish is respected wherever that is possible. Occasionally it's overridden in best interest, but that would actually be quite rare. So absolutely, it's actively encouraged and something to discuss with your doctor. Lasting or enduring power of attorney is a slightly separate thing. So that is where a patient no longer has capacity for whatever reason, be it a mental problem like an Alzheimer's or a dementia process, or they become physically so unwell that they become acutely ill and they're unable to communicate, that they have given health and welfare decision making on their behalf to a trusted attorney. So you only invoke that lasting power of attorney when you as a patient no longer have capacity to communicate your own decision, if that makes sense.
Yeah, fine, thank you.
And there are two types of that. One is health and welfare, and the other one is financial. And clearly we're much more interested in the health and welfare. Yeah,
thank you. Right, moving quickly on. Secondary care. This one for Steve. What's the patient choice of hospitals across the Herts and West Essex integrated care borders? Will my records be accessible if I go to a hospital in Herts when I've previously always been to hospitals in Buckinghamshire? And what is planned to improve communication and ensure medical records are shared between hospitals and the surgery? And this particular person had 3 ECGs at different hospitals. I'm not quite sure why that was, but there we go.
Okay, so I'll try and answer the question in a slightly roundabout way. I suppose the first thing to say, I'm not going to go through and mention every hospital in our area. I suppose the principle is, and Kate can correct me if I'm slightly wrong, is patient basically can have a referral to almost any hospital in the country if that service is provided there. But obviously we only know really more about the hospitals which are local to us, and some of those may have more. You'll have the general hospitals obviously, but you may have some hospitals which are more specialized in certain areas from that side. So the answer kind of is you can be referred to any of those hospitals which provide the care which you're looking for, and we will, I think it's currently that we aim to provide patients now with up to 5 options from where they can potentially kind of go to, but obviously 5 may not always be available for them. So there is that discussion with the GP, and there may even be some patients who do their own research on where they'd like to go. I think the key thing to remember though is that if you go somewhere, especially out of area, your pre-op, your op and your post-op normally are all with that hospital, and obviously post-COVID, when people were moving around the country a little bit more and being recommended to them, where a list was slightly shorter, to go to different parts in the country, that meant they had to go there, you know, for the pre-op, the op, and also the follow-ups. And obviously that can be difficult for a lot of patients. And obviously local hospitals will have their own potentially ambulance service for collections and all these sorts of things. And it's obviously a lot more kind of convenient. So I suppose the main thing is there's a wider choice as a hospital as they are as available. And I believe certain websites, and I believe on the NHS app at some point soon, they'll be providing further details on waiting lists in certain areas for certain conditions as well. So there'll be a lot more information out there. Just to show a picture on communication and what's kind of communicated between the hospitals and ourselves. So basically the East of England comes under a single system called My Care Record. And that's basically where main summary information from each hospital is available to others, and it's also available to the GP practice. Likewise, information from the GP practice, from the patient records with us, is also available to hospitals, and that in all of those areas. It also does include Luton and Dunstable in Bedfordshire, but that's as well, but it doesn't include Buckinghamshire. So Stoke Mandeville, for example, where most patients from Tring would tend to be referred to if they were staying local, they are working on a different system. We have asked the question about how we could be included in Stoke Mandeville's, you know, so there could be that cross communication of information, but obviously that's a decision way above our kind of pay grade to do that. But they have included the Luton and Dunstable because obviously there's quite a few practices within Hemel Hempstead and our area which also access that hospital. The sort of information's on the screen which is shared, and if you want to find out more information about it, there is a website, but if you put in My Care Record, then there's a website all about this information and how it's shared from that side. Unfortunately, as an NHS, we're not on one single system where people can access information. The GP practice still acts as a custodian for people's medical records. That doesn't mean we get all the detailed information from a hospital when you're discharged. We will get a summary of that. So if you're in there for a 2-week stay, we may just get 2 sides of a page which explains why you're in there, actions which the GP needs to do, and any considerations, for example, medication, etc., which needs to continue. We won't get the finite detail of every blood pressure check and every ECG you've had in that hospital. I suppose that's something just to be aware of. The other thing is also, if we refer out to a hospital, we will also provide that hospital with a summary or as detailed as that hospital needs for that condition. So we won't just refer you blind to a hospital. There is summary and medical information which goes along with that, which the hospital requests. But yeah, does that answer the question, George?
Yes, I think so, as much as it can be.
Can do.
And, you know, it's a perennial problem, cross-border issues. There's no simple answer. The next question was referrals to the musculoskeletal system service, and why has it changed from Connect Health, or will change from Connect Health to Circle Integrated Care? And will sessions still be held at Gossam's End, and will the current practitioners there be transferred to the new company?
So basically, the current people with the MSK contract called Connect Health, their contract comes to an end at the end of March this year. So that was put out to tender, and an organisation called Circle. So that's the organisation which people will be referred to after the 1st of April. From what I understanding, as normal process is their normal physios, etc., would be transferred across, or be offered the opportunity to transfer across. But the full range and scope of that new contract, we haven't got the full details of yet, but is something I think which will develop over time. The one thing we are aware of is that, as you may be aware, that we have first contact physios in the practice who are employed by the practice, and they will do an assessment on individuals who we see with MSK problems, and potentially then would have referred on to Connect Health to make a further assessment if that deemed necessary. Circle will now also have its first contact physios, and those first contact physios will basically work alongside ours, essentially doing the same job of assessing the patient initially and then basically referring them on if that's indeed appropriate. But because they're both working together, what it should do is shorten the pathway and shorten the time for a patient to be A, get referred, and B, get seen. We're basically taking a whole step out of it, because we would have normally referred to Connect Health, and then potentially they would have done another assessment again. Essentially, we're moving that second assessment away. So hopefully we should be able to move things forward. But hopefully more information should be available soon. We haven't got any details of yet of where Circle are going to base its main kind of physio outfit. You've obviously got the large room at Gossam's End, which they use on the ground floor. Personally, you know, that's already set up, so why would they move away from there? But obviously that's a business decision for Circle to make.
Thank you. I believe that they also have allocated space in Hemel Hospital.
Yeah, I think the aim is to, yeah, where they're going to be permanently based around the whole county. Obviously, we haven't got the full information currently.
Yeah. Right. Thank you. I think this one for Kate. How are shared care arrangements set up, and how do they work when caring for a patient's chronic condition between hospital specialty team and the patient's GP?
Okay, so a shared care agreement is where a particular treatment is initiated by a hospital specialist, and usually that treatment requires prescribing and then ongoing monitoring. So once a patient is considered stable, and this would be for conditions like rheumatoid arthritis, where sort of disease-modifying medications that are typically immunosuppressants, so will need some monitoring, are prescribed, or things like ADHD medication in children. So once a patient is stable, the GP, we're asked to sign a shared care agreement. And as part of that, so each one's a little bit different. It depends on the medication or the condition. But if it's something like a rheumatoid arthritis, we would take over the responsibility of prescribing the appropriate medication and its monitoring. So typically those medications need blood tests every 3 months. So we would do that. And then if anything unusual is happening, then we flag that back to the hospital. So, excuse me, I'm just going to have a drink of water. So in many cases, it's sort of hardly visible to a patient, and they continue to order their medication as they normally would. But if anything unusual is happening, so if a blood test suggests that there might be an issue, things might be, the disease might not be as well managed, or that the patient isn't tolerating the medication, or that some of the blood tests look a bit wrong, then we would go back to, it's our responsibility to alert the consultant team to that. And we might stop medication, we might do increased amount of monitoring, there'll be various things that we would do. That's typically done for, you know, a wide variety of conditions. ADHD is one of them, and that's the reason why you can't just go to a pharmacist and say, we've got this medication, it might be roughly equivalent to this one, can you prescribe that instead? because it's all done under shared care, and we don't have the ability to do that, if that explains that a bit more. Is that clear?
Yes, I think so. And there is a document on the website which we can provide a link to in the follow-up. We're getting to the end now of our session. Just want to reiterate that if you have questions which weren't answered that you asked, they will be communicated after the meeting with the slides, because we know that the slides aren't always easy to read. So we will make sure that everybody gets a copy of those and a general report on the meeting. And I apologise again in advance that the link originally shared with you was corrupted, unfortunately. So I had to send out a last minute change to that. And I understand some people did have difficulty logging in today using the new link, although we do have a reasonable number of people who did seem to manage to get logged in. So it wasn't all bad news, but and inevitably that's the problem with technology. And you have to recognize this is the first time any of us have done an event quite like this. So we've all been on a bit of a learning curve, but hopefully you've all found it useful and learnt more about the practice and how it operates and had your questions answered. So I'll now pass back to Steve and Kate if they've any further comments to make before we wrap up.
No, just once again, thank you for everybody. I think we've had over 50 patients attending today, so great to see you all, and potentially look to hold possibly something similar again in the future with different questions. Thank you.
Yeah, just the same. Thank you everyone for your participation and questions. We'd be delighted to follow up on anything else that we haven't covered or wasn't clear today. So thank you so much.
Right, thank you, and good night. And thanks to the team at the Practice for answering all these questions. So much appreciated, I'm sure, by everybody. Thank you.
Thank you, George.